So, dear friends and colleagues, a pleasure to be there in this very interesting symposium. You are the right position because we are talking about future. We are talking about future with, we are talking about new tools and a new concept. So we are talking about innovation. And for that purpose, I'm delighted to share the session with Javier Escanet. And you have a 5-star panel with Enrico Serrato, Michael Auranek, and Valeria Paredes, and we will going through. So we are talking about calcification also, complexity of calcification, and all the consideration that you have on the complexity to manage this patient. And we will talking about a new device, a new concept, which is mechanical lithotripsy. And for that purpose, I will ask, please, Dr. Serrato to share with us what is this new device and how does it work?
Okay, good afternoon to everybody. Thank you for coming here. So we will start to some concept just to explain you this novel technology. And basically, we know very well the lithotripsy. We are using it, but we are used to use a generator to have energy source to perform the cracking of the calcium. There is another source for this cracking that is a mechanical IVL that could exert this effort of force without the need of an external energy source. And this is the principle of the Hertz Contact intravascular lithotripsy. Basically, this is a concept, is a semi-compliant balloon, as you can see here in the cartoon, with multiple rows of stainless steel hemisphere, very little hemispheres that is protruding from the balloon and could anchoring in the calcium, as you can see. And so the force were focused in that point of contact, while this spherical shape ensures that the device is not provoking any lesion to the soft tissue. So the concept is to be hard on calcium. As you can see here in the image, you can imagine a hammer with a short tip that you can use to break a glass, for example, compared to a large hemisphere on your skin that is a soft tissue without any risk of damage. So the physical principle of this concept is the Hertz contact stress, that is basically the contact of the curved surface, in this case metallic hemisphere, on the hard surface, the calcium, that enhance an intense localized stress compared to the broad field effect on soft tissue. This is the animation just to again explain that using few atmosphere, as you can see, you can obtain a contact of the hemisphere. In the point of contact, the atmosphere and the force is multiplied per 6 or 8, while in the soft tissue there is no damage. This is basically the graph, as I mentioned. If you plot together the effect of the lytics on tissue, this row, and lytics on calcium, as you can see, the atmosphere and the contact stress that was exerted was very, very different. We know we have now data from clinical practice. This is, for example, the first case that we performed more than 6 months ago in our center with different pattern of calcium by OCT. And we can obtain fractures, we can obtain an effect of calcium modification, but maybe later we can elaborate more bit on this. From a technical perspective, what is important to know? The catheter, the balloon catheter, is a low profile, semi-compliant balloon surface, hydrophilic coating that is important because to enhance the deliverability of the balloon, and has multiple contact points. As you can see, the contact points are different. If you go for a 2.5 balloon, for example, there is 3 rows of hemispheres, while moving to 3.5 balloons, there is 5 rows of hemispheres. We have a different balloon diameter, as you can see, moving from 3.5, 3.0, 2.5, and we also have now the 2.0 balloon that is a novel IVL device, if you think, and you can use enhancing modification tool to better see the relationship with the calcium as a standard IVL. It's important to know this chart. This is a compliant chart because, as you know, we would like to have the contact of the hemisphere and the nominal pressure of 5, as you can see, for any measure, you can obtain the size of the vessel. But in some cases, if you have a vessel with a larger diameter, maybe you can use the same balloon at higher atmosphere, up to 12, 14, to get a larger size and to treat different size of vessel with the same balloon. This is potentially a difference with a standard IVL balloon. So, in my view, and we could elaborate also with Valeria with other cases, advantage could be the better workflow because you do not need any generator, any capital equipment, the trackability of the device, the advantage to treat a long lesion, maybe with different size. You can use in multi-vessel disease the same balloon, avoids the problem of pulse limitation because you can reuse the device multiple times. This is just a case to show you potential advantage. As you can see, complex case, long lesion, very calcified with counterpulsation. We need to use the rota because an uncrossable lesion. But after using rota, we have another problem. As you can see, we do not expand a non-compliant balloon. We start with lytics 6 times, different pressure to cover, moving from 3.0 and up to 3.5 in the proximal part. And finally, we obtain this result on calcium, cracking of the calcium, as you can see. And we end up with stent implantation with this result. The last point that I would like to point out, in my view, is that the 2.0 millimeter balloon is actually the first IVL technology available with this size. And so it's something that could be novel in our practice. As a potential advantage, if you think could be in regular or challenging PCI to avoid atherectomy, maybe in some cases that could be tortuosity, could be small vessels, branches, or to have more safety compared to atherectomy. And this is, for example, a case we perform up to now 5-6 cases with 2 millimeter balloon. This is a marginal branch. This is some bending, so not easy to reach the vessel and to cross due to the calcified part. We cross with this angulated super cross the lesion. The 1.5 failed to dilate. We move to a non-compliant 2.0, but as you can see, there is ruptures in multiple times. So if you go on with only balloon in this lesion, you can end up with a problem of dissection, perforation. And so we decided to test the 2.14 lytics. This is a live crossing of the balloon. Actually, the 2.0 is available only in 14 as a length. So in this case, the 14 cross, maybe 8 millimeter length will be crossed easily. But with a few atmosphere, as you can see, moving to 6, 8, 12 atmosphere, we obtain dilatation without rupture. We perform later other dilatation with non-compliant balloon, and we end up with DCB. In these cases, the final IVUS was good. We decided not to place the stent and not to jail the ostium. And this is my last slide. Thank you very much.
Thank you so much. Very nice and very interesting. And so this is innovation, but innovation without science is only an isolated idea. So we need science. So Valeria, please, can you share insight on the evidence that we have actually with this kind of tools?
Thank you very much, and good afternoon, everyone. So let's talk now about some clinical evidence for this very promising device. So the commercial use of this device has been launched less than 1 year ago. And you see here we have already 2 clinical trials and more than 1,500 cases performed up to date. The very first experience was within the Pinnacle first trial, first in men. 60 patients enrolled in 7 clinical sites in Belgium and in the Netherlands. I was part of the PIs of the trial, and half of the population also underwent an imaging analysis. The primary effectiveness and safety endpoint were residual stenosis less than 50% with no in-hospital MACE, and the safety endpoint MACE through 30 days with a 6 months clinical follow-up. The paper has been published in Neurointervention 1 week ago. So you see here that the clinical characteristic, the majority of the lesions were complex according to the American classification. We managed to achieve in lesion diameter stenosis less than 30% in 100% of the lesions, and the clinical success was 98.3%. So 17% of in-hospital and 30 days MACE. Let's have a look now at OCT imaging subgroup, some baseline characteristics. You see here the calcium length was on average 23.9 millimeter. That was according to the protocol inclusion criteria. And the calcium arch was on average 263, so almost 3 quadrants. But importantly, also the calcified nodule were found in almost 1/3 of the lesions. And at post-calcium modification OCT pullback, we could appreciate at least 1 fracture in 90% of the lesions and at least 2 fractures in more than 1/3, with fracture depth of 0.81 and width of 0.66. Very good results in terms of lumen area, stent area, and stent expansion at the level of MLA 100%, stent expansion at the level of maximum calcium size 103, and the level of minimal stent area 96.7. And also when we had to deal with calcified nodules that we know, we have learned the whole day, is probably the most challenging scenarios, we achieve a stent expansion of more than 100. And when we compare these results with previous studies, trying to achieve the 90% and also consensus document 80%, I mean, we realized how satisfying these results were. And now some clinical data in the, from real world. 102 patients were included at the one single center in Malaysia. 100% of the PCI were performed with intravascular imaging use, and a core lab also assessed all the images. The core lab was MedStar. 3 endpoints: the primary safety endpoint, the freedom from MACE within 30 days. The co-primary effectiveness of proportion of subject with residual stenosis of less than 30%. And the third endpoint, minimal stent area compared to performance goals and considering 4.9 square millimeter as performance goals, considering also the Asiatic population which was enrolled. When we look at the lesion characteristics, also here the 70% almost were lesion classified as C according to the American classification. 88% had a severe calcification. Lesion length was on average 19 millimeter, but lesion longer than 20 millimeter had an average length of 35.7. One device, lytics device, was used for all the lesions. And here are the results. You see here that the freedom from MACE was 96.1%. 4 cardiovascular deaths were not related to the use of the lytics. And the other endpoints, the primary endpoints, proportion of subject with residual stenosis less than 30% was 96.3. And again, the superiority in terms of comparison with the performance goal was achieved, was met with a minimal stent area of 6.89 square millimeter. When we look also at the lesion characteristics, you see that minimal stent area overall on average was very good, 6.89. Of course, a slightly higher in the concentric. For the concentric calcium, we know it's slightly easier to tackle, and the mean stent expansion was overall 113%. So the workflow we recommend for the use of this device is to assess always the calcium with intravascular imaging, predilate with a non-compliant balloon, a small non-compliant balloon, use a lytics device size 1:1 according to the vessel, size and optimize with a non-compliant balloon and, of course, intravascular imaging to assess your result. So to go back to this concept, reinforce how this system works with the low-profile metallic hemispheres, which are indeed embedded into a semi-compliant balloon. We create a point of contact which at the level of each hemisphere with the calcium, multiple points of contact with a minimal injury at the level of the healthy vessel. Thank you.
Valeria. So we move now to listen from you and to have your questions and comments. I'm sure that being a relatively new technique, I'm sure that many of you will have any comments regarding the device. Please.
Just a short question. Is there any data comparing it to a normal cutting balloon?
There are no data one-to-one comparison.
Do you want to elaborate a bit on the difference between cutting balloon and lithics, perhaps? I think that we have prepared some. Can we show the iPad for a second? Because it's interesting that obviously both of them are interacting with the plaque in terms of blades of the hemispheres, but perhaps you can elaborate on this.
Yeah, that's great. So you see here that we have multiple points of contact. So at each level, this hemisphere, we create a contact between the hemisphere and the calcium. So at each level, we will have a force, and at each level, the force will be amplified and then will propagate like this. What we have instead at the level of, when we use a cutting balloon, we have a point of contact at the level of blades. So here, here, and here, but we won't have multiple points of contacts. So what happens, you know, with the atheromes, that they will anchor in the calcium and they will create fracture, but it's just there. We won't have propagation, amplification of the force.
Valeria, would it be another example to say that it's the same difference than doing this than to doing this? For example, I mean, that's,
yeah.
Because I think that when you're, I think that basically what here you're doing is puncturing, is that correct? While the other thing is that is going with a knife flat and putting pressure, something similar to that?
I think that's a good point, very good point. And I think also when we do this, we will try not to break all the pens, but when we do this, then we also have a propagation in this way, in all this direction. That's the point, that's the concept behind this. So we have a force applying here and that this force will propagate.
You want to elaborate a bit on this? I think that you have here some, I think, sorry, that's the right pen.
No, this is,
yeah.
It works? Okay, yeah. Perfect. I cannot time in my presentation, but I think it could be important to highlight the mechanism of propagation moving from the superficial calcium to the deep part of the vessel. It's important to point out our attention here, basically, that is as a point of contact, as we mentioned, in which the force will multiplicate and we will directed in many different parts. So the direction of the first will be directed deeply. And there is also another force that probably start when the pressure ends and we start deflating the balloon. That is the propagation of the wave deeper in the calcium. And so this is a very good point to demonstrate that we can have both effect in different type of calcium. And maybe if you would like to show something about eccentric and concentric calcium, that
I think
could be also.
Enrico, what we discuss about this propagation, of course, Javier, is a kind of when you think about an earthquake and you have this propagation of the forces, that what we see here, we appreciate here. We discussed a bit about eccentric and concentric lesion. We also saw some results. I mean, of course, we all know that concentric lesions are easier to tackle. So what happened with this balloon is that we have a point of contact, multiple points of contact here. And then, of course, after that, we will have propagation of the forces. But what happened in the eccentric lesion? Here we'll have point of contacts here and here. Then, of course, we'll have propagation. But what it's important to underline is that according to this physics principle, so because of the module of the elasticity of the healthy vessel, which is very low, even if we have contact here and here, there won't be any trauma on the tissue, on the healthy tissue here. So that's an important message.
That's a very important message because we can expect that the main comparator is IVL with shockwave, which is high degrees of safety. So what we can expect from a new device is at least the same level of safety. And you perfectly shown in a mechanistic view that on healthy tissue, the risk of traumatism of the artery is quite low because of the Hertz effect, which doesn't apply. So that's a very interesting point.
So Benjamin, I think we could proceed forward because we have then Michael. I think that is going to talk to us. Michael Horanek, thank you very much for being with us. And I think that you are going to show us a case presentation highlighting some of the technical aspects of using the device in practice. Thank you.
So thank you very much for invitation and also to this session and to the course, which is outstanding in terms of treating calcium. I think that as it was shown, our experience with using lytics is growing. It's still not very high. For example, in our center, we just started the program. Nevertheless, our first experience were really, really good. I would like to present and show the case of 54 years old male who was first presentation of CED was the inferior MI treated with primary PCI. And the echo, fortunately, there was not big consequences of this MI with left ventricle ejection fraction around 50%, no other abnormalities. And of course, during this PCI, before this PCI, also the left coronary artery angiogram was performed. We can appreciate here quite tortuous and calcified lesion in the medial LAD. Of course, it was planned for the second stage revascularization. So the admission was 1 month later. You can appreciate, of course, that the lesion looks more or less the same. The most challenging part was this two angulation and, of course, very strict and part of this LAD due to the calcification. You can appreciate also here that it's by angiography, it looks more or less like a calcified nodule. Of course, as a standard in our cath labs, we try to start with the imaging, but it was not possible to pass this with the probe. So then we proceed with the NC 2.5 balloon with the initial predilatation. So the imaging still cannot pass, so we use the guideliner as the procedure was done by the 7 French guiding. So we use the guideliner to put the probe inside, so we can appreciate here definitely the mixture of the calcium types, especially with the eccentric and calcified nodules. So there was less part of the vessel which could be the concentric. As Valeria said, it is the less demanding scenario. So the eccentric and calcified nodule seems to be really challenging in terms of preparation. So for one of the first cases we have, and we thought from the very beginning that it is quite a tough challenge for this device. So, and you can appreciate on this angiogram also with the support of the 7 French guideliner, but just in the proximal part of the vessel. So you can appreciate that the balloon is coming quite smoothly through this really calcified and angulated vessel. So that was our first really, really good impression that the deliverability of this device is really good. So then we choose the 3.0 balloon. Nevertheless, the vessel seems to be bigger. As I told, it was one of our first experience. So That was the reason that we made multiple inflations, but to very high pressure just to achieve this more or less 3.5 balloon diameter. You can also appreciate how the balloon is expanding more and more with each inflation, and really a huge chunk of calcium in the distal part of this lesion. But after, you can appreciate also that the expansion of the balloon seems quite good. By the end of this predilatation, we also were able, of course, as for many of our balloon-based technologies, we always do the post-dilatation with the NC balloon. This one was 3.5, also with high pressure to 24 atmosphere. You can appreciate that there was clearly visible fractures in this eccentric part of the vessel of the lesion. Also, it seems that the calcified nodule was touched at least and in the 2 points. So we thought that we are ready to go to the stent implantation. So then, of course, as we are cooperating closely, and it was, as you can appreciate from the very beginning, a really young patient with the first presentation of coronary artery disease at the age of 54. And in our center, as we have the possibility of using bioadapter, so the second breakthrough technology, in terms of leaving nothing behind. So we decided to put to the most angulated part of the vessel, to put the bioadapter dynamics 3.0 by 23 millimeters. You can appreciate also that it goes quite smoothly to the distal part of the vessel. As this device is quite expensive, and at that moment probably we cannot afford to use all bioadapter for the whole vessel, so we choose somehow the hybrid approach. So for the proximal part we use Science 3.5 by 38 millimeters. So in the distal most angulated part and most calcified part of the vessel, there was the dynamics, and the Science was as in the proximal part of the vessel. Our approach to the bioadapter comes from the data which clearly indicate that the bioadapter on the left anterior descending artery behaves really great. You can appreciate their data from the 6 months. So when this device is starting to detach, is detaching. So the struts are never more connected, and the vessel vasomotion and also angulation is supposed to be the same as it was before the stent implantation. You can appreciate that the rate of the events in the LAD is really low, and even when we are looking only on LAD, this is 3 years data, so very long follow-up, and you can appreciate that the risk of TLF in this part of the coronary tree, so in the LAD, is 4 times less than the currently used stent platforms. So that was the reason that in our center, in young patients with the presentation of the atherosclerosis in the LAD, we always try to choose bioadapter as a first choice. After the stent implantation, of course, the imaging was done one more time. You can appreciate that at the site of the calcified nodule, there was MSA was around 5 millimeters, so there was not enough in terms of the goals we all know and would like to achieve. So we use the post-dilatation with 4.015 millimeters NC balloon. And although the lumen of the vessel is still not circumferential, the MSA was close to 6. So we decided that it is completely enough to finish the case. And of course, you can also see how the vessel was strengthened by these devices. And it was at the very beginning, we have 2 angulation. Now that there is just only 1. So we really hope that after the control hospitalization, which is planned 9 months after this procedure, so in the April or May, we can appreciate and look at that the vessel will look more or less the same as it was before implantation. So to conclude, this was the demanding scenario. So tortuous mid-LAD, eccentric calcium long segment, more than 50 millimeters with calcified nodule. The deliverability was great. The balloon crossed smoothly, but of course with guideliner backup. There was the effective calcium modification with 12 inflations along the entire disease segment, and well-visible calcium fractures even in the IVUS examination. Of course, the residual challenge, so the calcified nodule was moderately cracked, and probably, if I have to do the case once again, I will choose a bigger balloon, a bigger lytics balloon by half, so 3.5 from the very beginning. Thank you.
Thank you so much. This case is amazing. Huh? It's awful lesion, tortuosity, amount of calcification, massive. I was impressed about the trackability and the deliverability of the lytics, because we can expect that the crossing profile was entertained.
Exactly, it was the same for me. So I'm not always, have the, films from the to deliver the device, but it was really curious because it was, as I said, one of the first experience if this device can go smoothly. So that was the reason that this copy was also recorded, and that was somehow kind of surprise that it was really without any efforts. And you can, of course, we use the guideliner, but the guideliner while delivering the lytics was just in the proximal part, so it was not a deep intubation. So support was, of course, a little bit bigger. Nevertheless, it goes probably without this device. It can go also smoothly to the distal part of the vessel.
Do we have any colleagues who try this lytic system in the floor, in the room? Please raise your hand. The Discover one. Any questions? Please.
I just wanted to ask, because I read that you had 12 inflations along the area. Do you use it routinely for this balloon? Do it repeatedly and not like a normal NC, just cover it in one, cover the area?
The question is 12 atmosphere, is that a routine?
So and amount the numbers of inflations.
Number of inflation.
Yeah.
So I think it was pointed clearly that there is no limitation with the number of inflations. It's one of the big advantages of this device. So quite similar to the IVL, I think it's you can do it as much as possible to really prepare the lesion. So and don't think about the number you can use. Of course, the protocol is also that we should do this inflation quite for a long time, so for 15 to 30 seconds, and goes from the lower atmosphere to the higher one. This 22 was directly due to the fact that the balloon was a little bit too small for this vessel when we have the assessment. So definitely, I think we can use the same protocol or the same approach. So if you have to choose the balloon, it's better to oversize than to go from the undersized balloon.
Just a quick and practical question. When you deflate the balloon, how does it refold? So it's very difficult to move from the proximality to the distality once used, and you have to be backwards every time, or not?
No, it's not. I have a feeling, I don't know what my colleagues, I have the feeling that this hemisphere makes the movements much smoother.
That's surprising.
Yes, exactly. From to the distal and also from the distal to the proximal. It's like sense.
Good. I think that's fantastic. Thank you very much, Michael. Benjamin, I think that we can move now to the presentation of a case by Enrico Cerrato. So that's it's a presentation in acute coronary syndromes, I understand, Enrico. So that's looking forward to that. Yeah.
Yep, is a case presentation here. Okay, yes, it's basically a case performing in acute coronary syndrome, and is a 76 male in hemodialysis with a prior stroke, persistent atrial fibrillation with LAA occlusion, and a history of prostate and bladder cancers that after several days of angina, effort angina, come directly with persistent angina. And as you can see, the EKG show a ST elevation in inferior lead with depression in V1, V3 that could be classified as acute infero-posterior ST elevation. So we perform a primary PCI. This is a case, as you can see, starting from the left system, there is the absence of circ from the left system, and we have a severely calcified LAD. But the culprit lesion was judged to be this right. As you can see, there is not a complete occlusion of the vessel, but a subocclusion in the distal part. Is very tight and calcified artery. Here we can observe the anomalous left circumflex that originating from the proximal part, but is not the culprit of the coronary syndrome. So we start regularly with a big, good support with, as you can see, there is a AL catheter 0.75 and a regular Sion blue wire. The wiring is easy, but while I started to advance, a 1.5 balloon was not able to cross the lesion despite the guiding catheter support. So in such situation, with an uncrossable lesion, even with 1.5 balloon, what to do? I prefer in this case to use directly rotablation, and I move forward to reach the vessel, distality of the vessel with a rota drive, performing some atherectomy with a 1.5 bore. So after this procedure, I seems to have done the job, but this is still another problem. As you can see, the NC balloon was not able to fully expand in the mid-distal part of the vessel. So in this case, I prefer to move to a cutting balloon because I think that could be enough. But as you can see here from the live registration, the cutting balloon was not able to cross distal the lesion, even with this support that I have from the guiding catheter. And so I test the lytics. Honestly, I start with a 3.5 lytics because my purpose was to treat with a single device the entire length of the coronary artery. As you can see, the lytics was able to cross directly in comparison to the cutting. Using stent boost one system for enhancements, you can clearly say the pattern of the calcium. It's something that we perform regularly with any IVL technology, and also for lytics, as you can see the pattern of the calcification in that segment. So we started using the balloon. We perform 6 inflation. In the distal part, we perform moving from low atmosphere to 10 atmosphere because the sizing was 1:1 in our mind, basing by angiography. And so performing the dilatation, we obtain a full expansion of the device, as you can see. And we optimize also with non-compliant 3.5 dilatation and high atmosphere as usual. Then observing the proximal part, as you can see, there is here still an area with calcium, with not fully expanded. So decide to reuse the same balloon, the 3.5. And in this case, as we mentioned in the previous case, is a good to move to higher atmosphere, 14, even 16 atmosphere, because as I showed to you, the compliance chart in this case, there is the first line, the violet line. At the 5 atmosphere, we have a nominal 3.59, but up to 14, we can reach almost 4.0, and we can do some job on the calcium. In this view, we can use a single device. And we succeed in the dilatation. We optimize with 4.0 balloon is the proximal part, and then we deliver a stent. As you can see, the long stent will go smoothly in the distal part. We implanted 3.538 and the 4.033 in to cover the entire lesion. And this is the final result. In this case, we do not use imaging due to the setting of the complexity, but we have a complete resolution of the ST elevation and a complete resolution of the symptoms. This patient come back 2 months later because we would like to complete the job on the LID. This is a result in the right. And for LID, we try to use the same technology, and we focus on the mid part of the vessel. As you can see, we decide to advance a 2.0 lytics balloon, and we start perform dilatation. And as you can see here from the stent boost, we can succeed in the dilatation in the tight part of the mid LID. Then we work a bit more with balloon in the proximal part, and this is basically the final result after 2 long stent implantation to cover all the vessel with also OCT results. So to summarize, this is kind of STEMI elevation patients that could happen in our practice. Is not a thrombus, is not a complete occlusion, but is a subocclusion in a calcified vessel. But in some case, you have to deal with this kind of patient. Probably in such setting, you need bulking, the bulking to create the channel, but to do more with more aggressive bulking with a bigger rotabur with orbital, the risk of compromised final flow is higher. So in this case, it's better, in my view, to combine synergically the two technology, and you can use IVL. In this case, using lytics as IVL would be the advantage to be faster to prepare in such a setting of primary PCI, and also if you choose correctly the size, you can try to reuse the device to end up with a single device and do the job in all the vessel without using two different sizes of IVL. And so this is the final of the case. Thank you very much.
Thank you so much, Enrico, for this beautiful case again. Any comments? Please.
Thank you for the case. So you have a device just breaking the calcium, doing no dissection mainly, or no flow limiting dissection. Do you consider to do a DCB instead of long stenting? Because actually you are reaching a very good angiographic results. So a DCB should be considered maybe in such a situation for the LAD in the second case or in the second situation. Do you have any experience?
Yeah.
No?
Yeah, as we discussed tomorrow, and also Javier highlights this problem, in any case in which you are performing cracking of the calcium, you aim to obtain a larger lumen, and you have to be very comfort in terms of obtaining enough lumen, because the risk of using DCB is to have some sort of recoil, and so not to obtain in longer term a good result. So you can consider, because our aim as usual is to use a shorter stent as possible. But after reviewing the imaging, personally in this case, I feel not comfortable in terms of the lumens that I have reached. There is also a loss of the lumen, so I finally prefer to place a stent. But I think in that case, the imaging could help you.
Hi, congratulations, really nice presentation. How is your experience level? How many cases did you perform you personally?
With the lytics,
Yeah.
I think 30 cases
that's not bad.
was performed.
What would you expect if we just make randomized trial, IVL versus lytics? What will be the difference? Is everything the same or something better? What do you expect?
Very challenging question, but at this moment, I prefer, as I stressed in my first presentation, to talk about different of the technology, because in my view, the 2.0 is a novelty, because we do not have another 2.0 IVL. I have no such experience to have to test in a comparison the two technology, but the very good things is the trackability of the device. You can use multiple time, and you get finally you obtain a good job. In any case, we perform, we succeed. The one failure we obtained in trying to cross a very calcified diagonal branch with a 2.0 millimeter balloon, but we have also still problem with the rotabur that was stuck in that place, and so probably with a shorter 2 millimeter balloon could be better, but we do not have, and so I think that I will. The question is for you.
No, hard to say, maybe needed, but food for thought for sure. But I like the presentation. This is a new tool. We have to make our experience before testing. 30 case, 15 case, 100 case in the literature. So we have to expand again before trying, knowing the advantage, which is non-limitation of inflation, trackability we have inside, the trackability of the device. but also the limits that we have to know. So that's for the future. Thank you so much. We have to move on. Thank you so much. It was very interesting. And
one question.
Again, one question. Sorry. Last question, quick, please.
Yeah, short one. Price-wise, do you think it's going to be much cheaper than IVL? Cost-wise?
The cost-wise of the technology?
Yeah.
This is a question. At the end of the day, you have to do the job in your cath lab and for the patient. So I think that's it's the point that
you can discuss with the company, which is just
exactly,
at the end.
exactly. It's a good point for the companies as well.
Thank you so much. Thank you so much. So when we are talking with calcium, we are talking with frail patients. So Javier, you want to share with us a case, multivessel disease, frail patients, or daily practice in our cath lab? Javier, please.
Thank you. So in this case, I mean, like the case of Enrico, a situation that probably we will see more and more, patients with acute coronary syndromes that have lots of calcium, but certainly a situation that we see right now, patients that have lots of calcification typically is because they have associated unfavorable features. One of them, of course, is CKD, age, depressed left ventricular fraction, ejection fraction, etc. So in this case, we have a gentleman who is 89 years old, male. I haven't put the Frail score, but it's a frail patient, has arterial hypertension, diabetes mellitus, and as you see, a creatinine of 1.96. So it's a patient who has, by definition, high bleeding risk. Also, CKD, and the typical pattern that you may expect in this situation is stenosis all over the place with lots of diffuse disease, LED, so also circumflex right coronary artery, as you can see here. So in summary, we discussed what to do with this patient, but I think that in your, I'm positive that in your centers also surgery is less an option for these patients, or at least less the first option for these patients. And it was agreed that we should perform revascularization. We focus in the LAD and the right coronary artery, and we thought that, of course, we should perform ultra-low contrast PCI, not only to avoid acute kidney injury, but also, more importantly, to have enough room, leeway to perform thorough revascularization. Because if you are going to do revascularization in these patients, you have to do it well. Otherwise, it is not benefit associated to it. So I did the case with Julia Nardi. You can see Julia over there. And the first thing that we did is to gain information on the characteristics of the disease. And you can see that there is extensive calcification. You will see all type of patterns of calcification, like in the cases that we saw before, multiple rings of calcium that, as you know, are the big obstacle, particularly when you have superficial calcium, but you also see that there are nodules of calcium in the vessel. I think that's it. And based on this, we moved directly with the system. I don't remember, Julia, if we use a small balloon to go first. I think we use perhaps 1.5 balloon to go first with the system. But what I want to bring your attention is how actually, by applying multiple inflations, you can see that the plaque becomes modified. You see that the compliance of the vessel is improved, of course, because you see that the lithics balloon is opening very nicely. On the bottom, you have, as a reminder, of course, the structure that this lithics balloon has. We moved all over the place. This is the area where there was, as you remember, some concentric ring of calcium. And again, you can see that this was being treated successfully. You can see how it is opening very nicely with the inflation of the balloon. We, like Enrico, we also use stem boost or any stent enhancement technique to guide our intervention. It's a very nice way of gauging the gradual improvement that you have when you deliver the pressure. And again, as a reminder, on the bottom you have the graphic that was shown before, showing how actually in calcium the equivalent contact stress that you have is much higher than in the soft tissue. So something that is important in these patients who are very frail, very complex, where you also do not want to have complications. So that's, I think, is one of the aspects that we are also very happy of seeing: less chances of perforation, less chances of non-reflow, etc. So once that we have performed the plaque preparation, we always like to see the effect in cases like this, particularly with so much diffuse disease. What is the effect of plaque preparation using intracoronary imaging? As you can see here, we are using IBUS NIRS, but of course the focus is mainly identifying the modification of the calcific plaque that we have here. And it's possible to see, as we move forward, it's possible to see cracks, particularly in the areas that we noticed a lot of improvement in compliance, where we noticed that the lithics balloon was opening more widely. So up to that, after that, of course, we moved to high pressure balloon dilation. It's something that perhaps it was not highlighted in the previous cases, but we believe that is very important. I mean, once that you have generated fractures in the plaque, or you have noticed that you have improvement, then go with a larger balloon to optimize. And rotational angiography to make sure that the stent is opening evenly in all directions, anticipating if you have any problem. A stent in the proximal part. All these, as you can see, without any injections of contrast, because we are talking of ultra-low contrast PCI, assessment of the stent in this case, and as you can see, very nice opening of the, very good expansion of the stent. Just to show you some images here of all over the vessel. And then performing I would say that probably is the first injection or the second injection that we do, just to verify that everything looks good. And moving then to the right coronary artery, where we are skipping some of the steps, but basically following the same type of procedure and getting again a very good final result with a DS of 4.0 millimeters 26. So the takeaways of this case, we thought that it was a good case to demonstrate that this was safe in this complex scenario with an effective plaque preparation demonstrated with IBUS. Imaging was used in multiple aspects. Of course, one of them is to spare contrast as part of ultra-low contrast PCI, but also to identify calcium morphology, choose the lithics device, guide the stent optimization, and as I mentioned, the importance of using contrast techniques, the ultra-low contrast techniques in these particular patients. I don't know if I said, but it was something like 22 cc's of contrast, what we use in this patient who was certainly below the creatinine clearance. That is what we use as a guide of the maximum amount of contrast that we can use. Thank you.
Bravo, like we say in France. It's wonderful. Any comment on this superb case again? I got one. The first run of IVUS show every calcified pattern that you can find in a human body. And you treat it with the lithics, so it gives a very versatility of the action of this device.
Yeah, that's exactly. I mean, that we thought that this was a good case to show, because we have to keep this in mind, that in the patients that you treat, this is not a exception. In many cases, you have eccentric plaques, you have plaques that have lipids, you have all the type of repertoire, so you have to be ready to have a technique that is versatile, that can be applied more and more. In some occasions, like it was shown by Enrico, you have to use several techniques, because some of them have the ability to perform antegrade ablation, but then have to be followed by devices that can achieve a larger lumen and that have an effect in-depth transformation of plaque that you cannot obtain with rotational atherectomy, for example. But as you say, once that you overcome the problem of advancing a device, what you are happier if you have a system that is able to address all the different types of calcium, the patterns of calcium. Yeah.
Flavio, please.
Very short question. this is a great example of how to be cautious dealing with an 89 years old fragile patient. My question to you, Javier, is in the end you stented all the LED and the right. Until which point would you accept, for instance, a very focal spot stenting and leaving the rest without stent? Now it's very in fashion saying we drug coating balloons, but apart from the drug coating balloons, would you spare stents in a patient like this, or you don't care and you do as you did?
Well, for the time being, as you know, the evidence that we have from trials is massively in favor of stents. We are having incipient information about the use of drug-coated balloons in de novo lesions. So the 1N recommendation for drug-eluting stents that is in the clinical practice guidelines stays there. Once said that, it's true that you have to perform, so to speak, lex artis decisions in every patient and to be cautious, and and we are expecting the paper of solution de novo, which can be very interesting, but for the time being we still don't have a paper, so we don't know much what was going on. There was a colleague before that was suggesting to perform drug-coated balloon in a vessel that has 4 millimeters, etc. 4 millimeter vessel balloon, I mean, the chances of restenosis with a stent is minimal. I mean, these stents, if it is properly implanted, if it is implanted with IVUS, a 4 millimeter stents, I mean, they were not allowed in the Illumian 4 because the expected rate of restenosis of stent thrombosis is very, very low. So I take your point, and I think that also we saw Michael saying that perhaps there is a way in between that is trying to find stents like the bioadapter system that that has.
I absolutely agree with you. The risk of restenosis is not an issue. It's just because of the dual antiplatelet therapy. And he's 89 years old with 2 points of creatinine. That's the reasoning of thinking about sparing some metal.
It's a good point, but we don't have. I must say that we also don't have studies on that particular population. Again, how many studies do we have about reducing DAPT in contemporary stent implantations? And we are not talking about the using of IVUS guidance. We have many studies. But how many studies do we have supporting the fact that it is superior to use drug-coated balloon against this for this? We still don't have this information. So, but once said that, I will overtly respect, if someone thinks that was the best attitude for the patient.
We are just beyond the scope of the session a little bit because, we can spend an afternoon on DCB and calcified lesion, level of science unknown, So if I want to refocus, I think very interesting in each case, we have nodular calcified lesion. You show 30% of nodular calcium in Pinnacle. So much more than historic cohorts. So we have to face on the future and now on calcified nodule every day. And so far, do you think, Javier, that the lytics could be a good option of this kind of lesion, which is painful, actually?
I think it's a new technique, obviously, and there are studies that are being generated at this particular point. What Enrico has shared with us is that apparently the mechanism of action might work equally in nodular calcium than in that. I still believe, obviously, that probably there will be challenges, that coming from one of these things, but we are building evidence. We are getting more and more, and once that you have wider use of the device, I'm sure that we are going to have the answer to your question. Yeah.
Last question before closing.
Thank you, Benjamin. I am just asking a question to IVL experts, so as you are. So, Benjamin, you showed us that for shockwave, we have to use the full number of pulses. For the lytics, what is the fact? When the balloon is open, you stop inflating, or you think we may benefit to keep ballooning a little bit more when the balloon is fully open? When to stop?
So what we try to do is, as I mentioned before, to do visualization in multiple angles. So you see, if you see that there is full expansion, personally, what we will do is to go with a high pressure balloon afterwards. I think that is probably safer at this particular point. It's probably with other techniques. you may consider that you have achieved proper thinking. For example, if you are using IVL, for example, that you, in some cases, you may consider go directly for stenting based on the fact that with 4 atmospheres you have opened the vessel. But for this technique, in our limited experience, what we will do is to use a high pressure balloon afterwards. That is what basically you will do in all in this scenario always. Yeah.
Thank you. It's time to conclude, Javier. The final word is for you.
Yeah, well, it is my role now to take the role of the spokesperson and to share with you some key learnings. But I think it was a great session, Benjamin. I mean, we had the opportunity to revisit the principles of Hertz Contact lithotripsy. I think that is something that still we are learning. And we also, saw a number of scenarios where this device can be used, and more importantly, we were able to share with you also some cases from our practice. So thank you very much to all of you for the attention, and of course to all the colleagues that have contributed to prepare the session. Thank you.